This conference will now be recorded.
Okay, so welcome to the Obstretic EMQ session 4. Let's start with the question number 1. Now here you have to choose the most appropriate action for the management of labor. So 30-year-old multipara whose pregnancy has been uncomplicated in the spontaneous labor. She is after 2 hours in passive stage. She is encouraged to push. After 1 more hour of pushing, uh, for the vertex in occipital posterior position, that is +1. Head is 0 by fifth palpebral. So what should be the next most appropriate action? So clue patient has already. Yes, yes.
J.
What?
Manual
J.
rotation and Ventus delivery.
See, manual rotation is not that first offered method. And why two things you required? Either that baby can be delivered by manual rotation or forceps or rotational forceps or ventus, rotational ventus. So which is the good among three options?
No rotational forceps.
Rotational forceps, okay. Yeah, that also would be an answer. But rotational ventus delivery is the better answer. Because first they will try to use ventus because use of ventus is easy. They will just
Hmm.
fix at its point, and when you pull it, self rotation will occur. But the keelant require a lot more skill. So if the
Hmm.
conditions are favorable, so first will be rotational ventus delivery.
Ventus.
Yes, first will be rotational ventus, or if you have a caput or something like that, you think that the cup would fall. That time, most probably it will be rotational forceps, and manual rotation is the least used method.
Okay.
Yeah. So she has pushed for 2 hours, occipital transverse position, and +1 station. Head is already in the pelvis, so rotational ventus. So the patient is on gas and air for pain control, fully dilated. For 1 hour, she has no urge to pass, to push.
H. Epidural and commence into synod.
She's already on pain relief, but she doesn't want to push.
Does not have the urge to push. Then D. Sorry, E. Category 2 CS maternal indication.
Oh God, why cesarean section? So she doesn't see. She doesn't want to push. That means she's in a passive stage of second stage. So she's already fully dilated. Okay,
Acha.
she's already fully dilated. They wrote fully dilated also. So why you will do
Hmm.
cesarean? You can wait.
Acha, reassess after 1 hour in second stage.
Yes, that would be the answer. Reassess after 1 hour. Now this is a very common question that comes from this line. If the full dilatation of cervix has been confirmed in a woman without an epidural in place, but she doesn't get an urge to push, carry out assessment after 1 hour. Many times this question has been asked. Okay, so the patient nullibera at term, fully dilated for 2 hours. No urge to push. Contractions are inadequate. Fetal heart is reassuring.
Now we can give epidural and commence into synod.
Yes. So answer is H. epidural, and syntocinon. Because the key word here, contraction inadequate, and
Hmm.
baby heart fine. In UK, this is a new guideline. When the oxytocin is given, they want 3 to 4 contraction per 10 minutes. If it is more than 10, then that would be hyperstimulation. That time stop oxytocin or give terbutaline. Apart from this, like pain relief option has all CTG, like oxytocin. With oxytocin, they will do CTG monitoring and pain relief option. So low risk primary gravidine labor started contracting 3 hours previously. She is examined and found to be 5 centimeter dilated with intact membrane. Contractions are occurring every 2 to 4 minutes and lasting 30-40 seconds. So patient has. Do you think there is any problem?
No.
So what should be the answer?
E, option E, auscultation for 1 minute
Yes.
after event.
Intermittent auscultation would be the answer.
Hmm.
Okay. Because you can see she's progressing fine, contracting fine. So you have to do the intermittent auscultation, and O would be the answer. So this is about the fetal monitoring guideline. Intermittent auscultation. It can be done usually with a Doppler, PNOD, or a stethoscope. And after palpated contract, intermittent auscultation is carried out after a contraction at least for 1 minute, and it is repeated every 15 minutes in first stage of labor, and it is recorded as a first single rate in the partogram or labor care guide. And in UK, CTG is not put for every patient. So these are the risk factors, or these are the indications where they will do CTG monitoring, antenatal, and like the you can see already from here. So it is like specific conditions where mother or baby at rest, then only they will do CTG, not routine. So, a woman is hypertension induced for hypertension at 38 weeks. Prostaglandin is given to ripen the cervix. Later on, ARM and oxytocin. Okay. CTG shows tachycardia, variable deceleration, reduced variability for 30 minutes. She is contracting 5 contraction every 10 minutes, and the contraction is last for 45 to 50 uh, 50 minutes. It should be seconds. So what should be the answer? What is wrong going on here?
Here, hypertonus is there due to excessive contractions. Pathological CTG.
Hmm.
Um, we'll give um, C, option C.
C is what? Yes,
So administer. First of
but
all, stop.
oxytocin, because here
We
hyper.
have to stop at W.
Yes,
W is a better option, madam. Hmm.
the W is an option. And why W? Because the patient is given prostaglandin, oxytocin, so the hyperstimulation is there, strong contractions, and the nice wants 3 to 4 contraction. Here,
Hmm.
5 contractions. So
Fine.
we have to stop oxytocin and give terbutaline. So you new guideline 3 to 4 contraction for in 10 minutes. Okay, so you admit a patient with suspect.
Ma'am, I want to, ma'am, I had a question. In
Hmm.
question number 5, when I previous to this oxytocin question, there is two options. One is intermittent auscultation and one is option E.
Yes.
Uh, Ma'am, please see the option E.
Yeah, E is also a good option. Both could be the answer. Or E could be the answer and O could be the answer. Both are the answer. Same. Basically, O is intermittent auscultation and E is describing what is intermittent auscultation. Same. So, like in exam, the it will not be like that. Very clear exam. Okay, so the patient presented at 30 weeks with suspected preterm labor. Your clinical assessment suggests she is suspected preterm. So, what you will do next?
Speculum examination.
Speculum examination is done for
TPR.
yeah,
No,
yes,
sorry. TVS. TVS.
yes. If the patient is more than 30 weeks, then TBS or FFN to find out whether the patient is in labor or not. If it is less than 30 weeks, always treat preterm. So answer is TBS. Now the patient is 34 weeks of pregnancy. Initial digital examination, she is in preterm labor. TBS is not available. So what can be done?
Then H. Fetal fibronectomy.
Yes, FFN is an answer. So this is a summary for preterm. First, you will take the history. You will do PS or FFN. If it is less than 30 weeks, always treat the patient. More than 30,
Uh,
to take decision that whether the patient is in a preterm labor or not. So if the TBS length is less than 15 or FFN is more than 50, then the patient is in a preterm labor. Patient has to be treated. But if the cervical length is good, more than 15, or FFN is less than 50, then patient is not in preterm labor. You can send the patient back. So now, here the patient is admitted with suspected preterm labor at 28 weeks. Cervix is closed. Contractions are coming at a rate of 1 every 15 minutes. This is preterm labor management. What you will do at 28 weeks?
Tocolysis and steroids.
Hmm. Yes, tocolysis and steroid.
Option Q. Q.
Option Q is an answer. So the patient at 20, G2 P1, previous spontaneous preterm delivery at 28 weeks. At 26 weeks, now she is contracting. TBS is 6 mm, contraction 1 in 10. She is likely to be delivered within 24 next 24 hours. She'll deliver.
Option E. No, E. No. F. F. No.
Yes, F is the answer. When the patient is in about to deliver within 24 hours, so steroid and magnesium sulfate. So you have to give treatment, steroid and magnesium sulfate. So the patient has got a DVT in right leg. She was given UFH. 4 hours later, her APTT is 1.3.
Option H.
Yes, option H. So here comes the 1.3, second row. So dose increased by 2 plus, rebolus of 40, and next APTT 6 hours. So this is answer H. Now, the 40-year-old woman in accidental emergency with a sudden chest pain, learning and breathing difficulties. She's 35 weeks, having a massive and life-threatening embolism. Echo shows the cardiac the compromise.
Option E.
It should be E. So intravenous unfractionated heparin to be preferred when massive PE with cardiovascular compromise. Okay, so it is.
Hmm.
This is from the guideline only. So the woman is diagnosed with a severe embolism at 24 weeks of gestation. She is hemodynamically compromised with life-threatening ischemic complication from extensive vein thrombosis.
A.
Yes. So thrombolysis. So if in the massive PE, hemodynamic compromise with limb of life-threatening ischemic complication for extensive iliofemoral thrombosis, thrombolytic therapy is considered as an anticoagulant. It will not only reduce the obstruction in the flow, obstruction or in the circulation, but after thrombolytic therapy, infusion dose of UFH is given, loading dose is omitted. This is again from guideline number 37B. Now 30-year-old woman tested for thrombophilia is found to be C protein deficient, and test was performed because her sister has a DVT, and she was also found to be C deficient. So what are the risk factors?
Protein C deficient and family history.
So uh, this is high risk
In
thrombophilia, which
the
comes. What will be the answer?
I was thinking option K from 28 weeks until 6 weeks postpartum.
28. See, family history and protein C deficient. Hmm.
Then it will,
Basically, answer should be H, isn't it? You have to start
throughout
from
the antenatal period.
yeah. So answer should be H, because if you see from here, this is the protein C and S deficiency. The patient comes here, this category. Patient is having asymptomatic high risk hemophilia. So patient is at intermediate risk. So ideally refer to local expert, consider antenatal and postnatal. Okay, so here it is coming. So they have not mentioned the gestation. So you start it now and give 6 weeks postnatal. Okay, the woman has got antiphospholipid antibody. Her BMI is 33, age is 36. She has got no uh, risk factors, family history. So she has got how many risk factors?
Three. Age more than 30. The age is 36 years. Antiphospholipid antibodies and BMI is more than 30.
So what would be the
So
answer?
this is this is K from 28 weeks since score is 3 till
Hmm.
6 weeks. Yes.
Yes, three risk factors for 28 weeks to 6 weeks postnatal. So the patient is HIV positive or found to be HIV positive on booking. that screening test for NPL ID and the counseling about invasive testing. So 43-year-old woman, drug abuser, came for booking at 17 weeks of pregnancy. She knows the baby has got high risk. She wants amniocentesis.
Option G.
No, why? We don't know whether she's HIV positive or not. Option F, you can defer the test till you are sure of HIV status because the blood has been sent. Okay.
No, ma'am. First, it's written it's either known to be HIV positive or found to be HIV positive at booking. First line.
Women either to be HIV positive. For each woman, the screening test. Okay, if she is positive, then that answer will become G. Known to be positive or were found to see no were found to be HIV positive at booking. But this patient they didn't mention whether they have found out or not. Either patient is HIV positive or were found to be HIV positive at booking. So they are doing test at booking because question doesn't mention she is positive. Now this will go. So the patient has got HIV result come positive. She has to go for CVS. So what will be the answer?
Hmm. Option G. মানে viral load.
So here, because here the patient has got confirmed HIV, so here you can defer till the viral load is less than 50. So G is the answer. So invasive, this is from the guideline Viva. Invasive perinatal diagnostic testing should not be performed less HIV is less than 50 copies per ml.
Hmm.
Now here the patient is delivered to HIV positive woman. So for the baby who is born, you have to find out about the screening for HIV.
Hmm.
So baby, so infant delivered HIV positive mother at 40 weeks. He was placed in Zuru for 2 weeks. Now she is discharged 12 hours after delivery with mother.
Hmm. Option F.
I. What is the difference between F and A? HIV RNA at 48 weeks, at 6 weeks. With regards to screening delivered. So here, what here they didn't mention anything about breastfeeding.
Hmm.
From here, I put the I. Non breastfeeding infants HIV test 2 days prior to hospital discharge, 2 weeks, 6 weeks, and 12 weeks. And this is for seroconversion if the antibodies occur at 22 to 24 weeks. So here the question doesn't describe about the breastfeeding status. So they're not saying baby breastfeeding. So you have to speak about the non-breastfeeding. So non-breastfeeding will be for 2 days, 6 weeks, 12 weeks, 2 days, 6 weeks, 12 weeks, and 24 month for antibodies. So same, 28 hours. 2 weeks also should come in high risk cases. 6 weeks, 12 weeks, and 18 to 16 month post delivery for antibodies. Now here the HIV woman on cart, and she has viral load less than 50. She was given Jitavudine. She has decided to breastfeed the baby. So what will be the monitoring method?
Now it will be F, breastfeeding. 18 to 24 weeks will not do antibody.
48, 2 weeks, monthly, and 4 and 8 weeks. Antenatal antibody at 24 to 28 weeks. These are the HIV tests for like breastfeed infant.
No.
For breastfeed infant, whether the maternal antibody testing would be done or not, that was not clear in the guideline. So this is written in the guideline. So breastfeed infant at 2 days prior to hospital setting, 2 weeks monthly till breastfeeding, 4 weeks and 8 weeks after cessation of breastfeeding. But if the patient is already breastfeeding, so the baby would be getting maternal antibodies already.
Hmm.
Because of that, they are not doing testing.
No.
Because the passive transfer of antibodies would be there.
Hmm.
MCDA twins, complicated by TTS. Endoscopic fetal ablative laser was done 24 weeks. Now 30 weeks of gestation. So one baby 7 centile and systolic flow is present, and Doppler MC Doppler is also fine. So what is the plan for delivery? So patient is fine only, isn't it?
Hmm.
Dopplers are fine. So patient is treated for TTS when they should get delivered.
36 weeks.
34 to 36 weeks. So delivery of monochorionic twin complicated by TTS should be in between 34 to 36 weeks under steroid cover. Okay. So answer is F. Okay. MCDA twin is now diagnosed severe growth restriction with abnormal ductus venosus, and computerized CTG shows short-term variation.
Option E, administer corticosteroids and neurotoxins.
It should be E. So 30 weeks reverse flown Doppler, so steroid and deliver. So 30-year-old woman with MCDA twin, type 1 selective fetal growth restriction. Growth is fine. She has done scan by 32 weeks. When she should deliver? So type 1, when you want to deliver type 1?
Type 1 is 36 weeks.
34 to 36 weeks. MCDA twin. Now, this is second pregnancy. Now, growth discordancy 15%. Small twin has 2 centimeter of DVP. Large twin 7.8. Umbilical artery shows endostolic flow. MCDA twin. MCV MCA of small twin is 1.6. And a higher twin is 1. So this is what the- so the M is the answer. She is 28 weeks, and the like uh, uh, SGR is going on. Both baby has got DVP less. Both discordancy is there. So every 2 weekly fetal Doppler assessment by MCA, umbilical artery, peak systolic velocity, and so answer according to that goes to M. Is it clear?
Yes. No.
Very difficult guideline. So the patient is seen at 20 weeks, biometry performed for Laker quantification, suspicion of TTS. At 20 weeks, suspecting TTS, or they should monitor.
2 weekly biometry.
Yes, twice weekly ultrasound with umbilical artery. Like this also you have to remember umbilical artery PI, MCA PSV, DVP, and effective of fetal weight. Okay, so you have to see 23-year-old carrier of a hemophilia A 6 centimeter dilatation and plague that has persisted for 30 minutes. Now, she was told in USG that she carrying a male baby.
Option E.
Category 1. Variable decelerations are there, so you can do category 2. It is not pathological CTG. CTG is okay, okay. Variable
Hmm.
deceleration, not. Variable decelerations are there without any features. Not even a number sign.
Hmm.
So this is normal kind of CTG. So you can do category 2 cesarean section. This is in the guideline. So planned cesarean section to be discussed for affected male baby, especially in severe hemophilia, or if the fetal status is not known. 37 weeks gestation planning for delivery. He is a carrier of hemophilia B with a male baby having moderate to severe hemophilia. hemophilia.
Option D.
Yes, very nice. A cesarean section to be done by 39 weeks. So elective cesarean by 39 weeks, planned section, if the baby status is not known or if it is a male. Okay. Now here there is a questions about the breech presentation management. Multiple at 35 weeks. She has got the counseling for the vaginal breech delivery and USG vaginal. Yeah, and she had an uncomplicated vaginal delivery of 3.4 kg baby 2 year ago. USG scan shows today complete breech with a weight of 3 kg. What you will do for multi?
Yeah, ECV at 37 weeks. Okay.
Yes, ECV at 37 weeks. So the 29-year-old woman undergone ECV. CTG shows a fetal bradycardia.
Proceed to C. No. Proceed to CS.
Why you will do CCS? You will not wait. You can
हाँ
wait.
but I will
Conservative.
not do ECV.
Yeah, yeah. You will do because she's only 36 weeks. Why you will deliver?
Hmm. Hmm.
So you can wait and watch.
Yes.
Continuous monitoring left side for 6 minutes. Now this is in the guideline. Like if the patient has fetal bradycardia, then continuous monitoring in the left lateral position. If it is persistent, not improving even after 6 minutes, then prompt preparation for category 1 cesarean section. So ECV is attempted. 4 attempts are done in 10 minutes. What you will do next? The 4 attempts are already done.
A.
Yes. You will abandon it now. 30-year-old, the single most appropriate next step. 30-year-old woman, epistomy was given. She would administer 1% lidocaine. She has lightheadedness and twitching, collapsed. What you will do? Lignogen
Hmm.
toxin.
Hmm. Option R.
Yes, intralipid you will consider.
Ma'am,
Yes,
ma'am, sorry to interrupt, but here it's asking most appropriate next step. So we'll do common CPR or intralipid?
ideally it should be next step. See, next step would be always if the patient is lost consciousness, it will be ABC only,
Hmm.
and after that, you will do the like this, the appropriate thing. But ABC is not in the option.
Option R. Okay.
So the patient is 30-year-old. Features of septic shock. She is hypotensive, hypothermic. Antibiotics are being given. Lactate level is 6.
Option W. No, Q. Confused between Q or W.
It, first, you will give her crystalloid. Vasopressins are only given when you are unable to maintain blood pressure with fluids.
Oh,
So this is a sepsis 6 care bundle. So rapid administration, minimum 30 ml per kilogram of crystalloid to be completed within 3 hours of diagnosis. Once adequate volume replacement achieved, then vasopressin or vasopressin, adrenaline addition, or inotrope dopamine can be given. We want to maintain mean arterial pressure less than 65 mmHg. So the patient with GBS administration has urticarial rash and difficulty in breathing. She has multiple bronchi.
G. Option G.
Yes. This is anaphylaxis, and this is a treatment for anaphylaxis. So ABCD approach: lay and remove the trigger, lie the patient, raise the leg. For the apart from this, give 0.5 ml of adrenaline 1 in 1000 IM, chlorpheniramine in 10 milligram, hydrocortisone 200 milligram IV or slow IM or slow IV, as well as airway support. Okay, single most appropriate option. 22-year-old patient with 39 weeks of gestation, uncomplicated pregnancy after full dilatation. She progresses to full dilatation after 8 hours. She has epidural second passive stage for 2 hours. After that, she has pushed for 1 hour. Vertex descent to +2. Ventus has already been applied 3 times. Head at perineum. So, which also succeeds. So, what to do next?
Option G.
Gee. See, 3 attempts are done.
Hmm.
Now there are 2 options left. Either in
L.
expert hand forceps or cesarean. But the head is too much down. Perineum. At perineum, the head is there. So you can consider
Release forceps.
forceps. Yes, because uh, uh, like 3 pulls at the perineum can be given according to new guideline. So multigravid and spontaneous labor, she rapidly progresses to full dilatation. She started pushing. After 1 hour, the baby is not delivered. Head is 2 by 5 palpable. Vagina vertex is +2 with molding and caput. What you will do? So the patient has already pushed, you know.
Emergency CS. There's caput and molding.
Yes. So patient is multi pushed for 1 hour. Head is 2 by 5. So that means already almost in the abdomen. So cesarean section. So the patient delivered 1 week ago. She's a diagnosed case of sepsis. Broad spectrum antibiotic given. Crystalloid are given, but blood pressure still remains low. Now it will be
Inotropics and
yes.
vasopressors.
So now F vasopressors can be given to maintain the
F.
blood pressure.
Hmm.
Yes. So 31-year-old with a spontaneous miscarriage following rupture of membrane. She has like her is offensive. Few days later, she has a generalized rash. She was started with antibiotics, the sepsis care bundle. She deteriorates despite antibiotic combination. She's not responding to anything, isn't it? So
Mm.
what do you believe?
Option
Hmm?
B, transfer to intensive care unit.
IVG and fluid warming device. Because oxytocin, there is, if you see in your guideline, there are indications of transferring to ITU is there, but here the patient not responding to antibiotic, and she's having staphylococcal or streptococcus or staphylococcal infection because they have given macula, okay,
Mm. Mm.
rash. So they have uh, uh, like they have got exotoxin. So this is basically a exotoxic shock. So to neutralize that, you have to consider giving immunoglobulins. So
Uh,
low administration of IVG with fluid warming device. This is again guideline number 64A, sepsis. So patient develops fever. She is admitted with the labor at 40 weeks. She has fever. Antibiotics, antipyretics are given. Temperature has fallen 237. Diagnosis of sepsis is made. Electronic monitoring started. Blood samples are sent. The patient is baby is having tachycardia with reduced baseline variability and persistent late deceleration. So what you will do?
M. N.
Okay. If the patient has sepsis, so basically regional analgesia, spinal or epidural,
Mm.
is avoided, and GA should be given. So answer is L. This is a picture of chorioamnitis. So you have to deliver the baby fast. But the catch is sepsis. It is epidural and spinal is not given because sepsis is associated with thrombocytopenia. So there could be hematoma. So GA is given. Okay, so 24-week gestation with recurrent herpes. First episode 6 months ago. Was treated with acyclovir, no lesion on the vulva. So the patient is having recurrent herpes.
Option D.
Yeah.
Option D.
Yeah, but in the new guideline, it has been changed acyclovir from 32 weeks. Okay. So this is a new
Mm.
answer from new study. So 40-year-old patient complains of painful vulval blisters. 6 centimeter dilated with rupture of membrane. PCR has been sent. Cesarean section has been discussed, but she wanted vaginal birth. So the patient with a primary herpes with prom, she wants vaginal
IV
birth.
acyclovir. IV
Yeah.
acyclovir.
Which is the answer?
Mm. N.
Yes. So it is less dose to the mother, that is 5 milligram per kilogram of body weight, and it is high dose to the baby, that is the 20 milligram per kilogram of the body weight. So the 33 years old woman with leakage of water per speculum shows vulval blisters. Clear fluid is coming. Diagnosis of prom is made. Blister, uh, fluid sent for PCR confirms herpes infection. This is first episode. So first episode prom 33 weeks. So what you will do? Patient is going to
Ma'am, I
deliver.
will, uh,
Hmm.
so I will give IV acyclovir, but corticosteroids will be, I'm confused with
Yes.
that.
answer is G. You will
G.
consider giving steroids and IV acyclovir 5 milligram per kilogram body weight 8 hourly. So intravenous acyclovir, this is PROM, genital herpes and PROM. So IV acyclovir until delivery and prophylactic steroids. So patient 31 weeks attends booking at 12 weeks, and she reports someone with chickenpox. She's from tropical country, can't remember whether she have chickenpox or not.
W.
Test has not been done by W.
No, we'll test her for immunity.
So answer is E. Blood test to determine immunity.
Mm.
So 23-year-old seronegative for herpes, chickenpox antibodies for contact with she has a contact with chickenpox. She's 20 weeks. So what you will do?
Mm. As per new guidelines, we will give acyclovir from day 7 to 14. But here we
No.
will give the option
Yes, yes. So acyclovir according to new guideline from 7th day of exposure to 14th day, and the patient should be referred to the FMU. So H. Okay. So now this is the about the description. The woman suffer from epilepsy in pregnancy. So 29-year-old woman admitted at 38 weeks. She is 5 centimeter dilated, CTG fine. She has clonic lasted for 6 minutes.
F.
Ideally, answer is F if the question mentions that IV access is there. Question doesn't
Oh,
mention anything, so fastly we will consider rectal dissection. Okay, so the patient has tonic-clonic convulsion is 40 weeks. She's epidural in place. She started having seizure. IV lorazepam start dose was given, but 10 minute another dose was 10 minutes later. But this doesn't control it. Seizures. What you will give?
IV phenytoin.
Yes. So this is the from the guideline. In status epilepticus, those who have IV access, lorazepam is given. Otherwise, diazepam, like intravenously is alternative. If IV access is not there, then rectal diazepam is given or midazolam 10 milligram buccal preparation. If if seizures are not controlled, IV phenytoin given was as an IV infusion. Now, a 23-year-old woman referred by midwife with FS facing a fetal with her sympathio-fundal height only 26 centimeter, SC less than 5 centimeter, AC less than 10 centimeter, SC less than 5. So baby has microcephaly. Liker is normal. What is a and mild hepatomegaly? So what is what should be done?
CMV. Um,
It should be CMV only. Cytomegalovirus. So here 22 weeks of pregnancy, no structural anomaly, baby small, polyhydramnios, uterine arterial Doppler, no risk factor in SGA.
Karyotype. F.
Yes, karyotype F is the answer. So this is from the new guideline. Before 23 weeks, if no structural anomaly, uterine artery Doppler, baby have STA, consideration for invasive testing. So 20 weeks echogenic focus in the abdomen and the brain, no further test, and she has hydrocephaly and AC less than 10 centi. Umbilical artery Doppler normal.
Tox toxoplasma.
Yes, hydrocephalus, toxoplasma. Now, but here, patient with blood pressure of 166, 110. She's asymptomatic, no proteinuria. That means she's having gestational hypertension, and USG scan shows normal growth. She has been admitted for control of BP on with levotalol. So, what will be the plan? Basically, it is difficult to find. It is the gestational hypertension. When the gestational hypertension admitted, then daily monitoring of blood pressure to be done. And if the USG is fine, then repeat USG will be done every 2 to 4 weeks if it is indicated. This is according to new guideline. Okay, so better idea is to remember new guideline. So this is the management of the gestational hypertension. Patient is admitted. So okay, no. It is not daily. Blood pressure measurement is uh, like it is not matching basically because why the patient is admitted. I think it is not about this only. This is the gestational hypertension management. When the patient is admitted, then like they will admit the patient if it is more than 160, 115. Then they will do every 15, 30 minutes until the BP is less than 130, 110. And so this much is given. Now, what will happen when she will be discharged to the community? It is not written here. Apart from this, fetal heart, if it is fine, so they will do the like they will do like repeat USG every 2 to 4 weeks. So, if the patient has severe gestational hypertension, USG will be done every 2 weeks. If it is like um, if it is only hypertension, then it will be every 2 to 4 weeks. So the patient that what we are discussing, she's having gestational hypertension. Now the blood pressure dropped to this much. How much pressure is fine only? What is happening?
You can give him option D.
These what? These kidney function monitor weekly.
Hmm.
Blood test. Yes, this could be the answer. Monitor weekly. Monitor weekly could be the answer. So D could be the answer. Patient to be monitored weekly. This could be the answer. Now another question. Okay, this is confusing. So here the blood pressure is 155, 105 at 35 weeks. Patient is on levotalol. Growth is normal. Urine is negative. Midwife will check blood pressure twice weekly. So what will be the plan for the baby?
Okay.
Huh?
Okay. C or M.
Basically, every 2 to 4 weeks.
Hmm.
According to the according to this, if the patient is blood pressure is this much, 150 less than like this much is the blood pressure 155 and 105. The patient falls in this category, hypertension category, and this is all about the baby. This is all about the baby. Carry out a USG diagnosis and repeat every 2 to 4 weeks. But in this question, USG now and every 2 to 4 weeks should be the answer. That is not there. In that situation, you can consider M.
She is already 35 weeks.
Yeah, she is already 35 weeks. So if the USG is fine, then it should be done every 2 to 4 weeks. That is the rest. What could be the answer? Or again, blood pressure. D could be same answer. D could be the answer. D could be the answer. Monitor blood
Hmm.
test weekly. So D could be the answer. Okay. So both have got the same answer. Monitor weekly. Actually, the guideline question is from the previous guideline, and the this table is from the new guideline. Okay. Basically, remember this as
Hmm.
a hypertension management, and this is the baby management. That's it. Any question? Any any question?
No, ma'am.
Okay. Thank you.